This is a discussion on postural orthostatic tachycardia syndrome or POTS. Postural orthostatic tachycardia syndrome is characterized by orthostatic tachycardia in the absence of orthostatic hypotension. Criteria for diagnosis of POTS are as follows. 1. Heart rate increase more than or equal to 30 beats per minute from supine to standing. 2. Symptoms get worse with standing and better on lying down. 3. Symptoms lasting 6 months or more. 4. Absence of other overt causes of orthostatic symptoms or tachycardia like active bleeding, acute dehydration, and medications. As children have higher orthostatic tachycardia, a cutoff of more than or equal to 40 beats per minute within 5 minutes of head-up tilt has been suggested in young children. An orthostatic heart rate more than or equal to 130 beats per minute for ages 13 years and younger, or more than or equal to 120 beats per minute for ages 14 years and older has also been suggested as additional criteria. Both cardiac and non-cardiac symptoms can occur in POTS. Cardiac symptoms include rapid palpitations, lightheadedness, chest discomfort, and dyspnea. Non-cardiac symptoms could be mental clouding, headache, nausea, tremulousness, blurred vision, poor sleep, exercise intolerance, and fatigue. Fatigue resulting from activities of daily living such as bathing or household work can cause significant limitation of functional capacity. Large majority of patients are females in the age group 13 to 50 years. Lightheadedness was found to vary in them during the menstrual cycle and may be related to changes in estrogen levels. It was more during periods and less during follicular phase. They also reported an increase in estrogen-related gynecological disease. Clinical examination may show features of mitral valve prolapse, though significant mitral regurgitation is rare. Dependent acrocyanosis is a striking physical finding which occurs in 40 to 50% of patients. A dark red-blue discoloration of legs which are cold to touch can be seen. Two important phenotypes of POTS are the neuropathic POTS and central hyperadrenergic POTS. Partial sympathetic denervation, especially of the legs, with less norepinephrine release in the lower extremities has been documented in some patients with neuropathic POTS. Excessive sympathetic discharge may be the underlying mechanism in central hyperadrenergic POTS. They often have extremely high levels of upright plasma norepinephrine. These patients may benefit from central sympatholitics like methyl-dopa and clonidine. Peripheral beta-adrenergic blockers may also be useful in these patients. Some patients with POTS present with episodic flushing and have coexistent mast cell activation as evidenced by increase in urinary methylhistamine. Pheochromocytoma can be considered in the differential diagnosis of POTS because of paroxysmal palpitation, but they are more likely to have symptoms in the supine position and have high plasma norepinephrine levels. Plasma or urine levels of metanephrines have about 98% sensitivity for detecting pheochromocytomas. Holter monitoring may be useful in excluding paroxysmal arrhythmia in case of paroxysmal palpitation. Sometimes the symptoms of POTS may be mistaken for anxiety disorder and panic disorder. Neurally mediated syncope or vasovagal syncope can have symptoms similar to POTS, particularly in the immediate pre-syncopal phase. Here are the first set of relevant journal references. Second set of references are here. These are the third set of references. Thank you for watching this video. Please subscribe, like, share, and post your valuable comment below this video.